we're going to take a closer look at a project she did at her organization in terms of workflow management, documentation burden in that capacity at her organization. So when we think about and start wanting to address documentation burden, to really understand that and address those struggles, we were fortunate enough to have our ANIA'S Board of Directors develop a conceptual framework. And that framework was published in June of 2020, and it helped define many of the forms of documentation burden that's experienced by our colleagues. So to give you a highlight, these 6 domains: reimbursement, that talks about the documentation or the coding and administrative data entry tasks that are needed, obviously, for payment. Then we also have a domain of regulatory. That's those accreditation and agency documentation requirements that kind of burden us all. There's also the burden of quality, and that speaks to the documentation that's required to demonstrate that you have performed adequate patient care. Usability, that's a limited and insufficient use of the human factors, engineering, and human-computer interface principles that we're all familiar with. Interoperability and standards, that speaks to the insufficient configuration standards that results in that duplicate and re-entry of data. And then, of course, we have that self-imposed domain. That's where organizations have kind of put it on themselves, or we as a nursing practice have put it on ourselves. It's the influence that the organization has on what should be documented that can exceed what is really actually needed in terms of care. If you also are an avid ANIA webinar listener, you probably recall Dr. Harmon speaking to this in her presentation in October. So between that webinar and this awesome framework that's put together, those are great resources for anyone wanting to learn a little bit more about what documentation burden means and how to go about addressing that. For me, though, it boils down into really finding the right balance. Balancing why we need to document versus what needs to be documented. What I mean by that is we have to be able to communicate with our team members, yet what's really truly relevant for them to know. Detailed documentation is oftentimes not overly helpful in the grand scheme of patient care. In fact, it can become sometimes more confusing because it gets to be too much for our peers to comb through to find out what's really important, what they really need to know. The other balance is balancing what regulatory standards are needed versus what's really required. We have to be able to correctly interpret those CMS or Joint Commission, whatever accreditation agency you use, but correctly interpret those regulations to make sure we're truly addressing what the standards are saying. So we have to understand them. ANIA'S position paper does indicate that not every standard requires a note or documented element within the record. And I know from my organization, we found that to be really true most recently around restraint documentation. What was built in the EMR was far more rigorous than what was really needed in the standard. So we kind of did this to ourselves, thinking we were meeting what a regulation required of us. That ties me also into that balancing act of what's quality medical record, like what does that mean, versus having enough adequate evidence to say, here's the patient's story in a legal case. You need to be able to prove the care was provided and the standards were followed without overtaxing those who are actually doing those acts of care. And I really wish I had better insights on how to navigate this particular balancing act, because I know from my own experience, our legal team, they always have a desire to have more in the chart. They need to have a better story. But at what cost does that then come from those that are actually delivering the care? So this is really more of the art rather than a hard and fast science to documentation burden. So with that, I'm going to pass it over to Brooke, who can tell us a little bit more on the project that she did at her facility.
Hi, good afternoon, everyone. I'm Brooke Gaskins. I'm a manager in the Department of Clinical Informatics at the University of Maryland Medical System, and it's my honor to be here to talk to you today. With the current challenges in staffing, surges due to COVID, and ever-increasing demands on nursing, the need for a system-wide strategy was identified to address documentation burden. It was coined Project WEED, which stands for Working to Eliminate Excessive Documentation. There's decades of self-imposed burden due to the belief that if it's not documented, it wasn't done. The impact of the EMR on our colleagues has also increased the incidence of documentation burden and may lead to nurse burnout. Most importantly, increased documentation burden decreases the amount of time spent with the patient and creates unnecessary hurdles to receiving care. There are factors that promote documentation burden. The first is people, which includes examples such as, I've always done it that way. This creates a generation of nurses passing down the same ideology, creating self-imposed burden. Another is, if it wasn't documented, it wasn't done. This has led to nurses filling out every field instead of only documenting pertinent negatives. The ability to select within defined limits allows them to indicate a normal assessment, but this has not been fully adopted by nursing. When other nurses taking care of the patient see that all of the fields have been filled out, they follow suit, creating self-imposed burden. Another is not documenting at the bedside or in real time. Training and educating preceptors, charge nurses, nurse educators, and managers to have the same documentation expectations can alleviate documentation burden. We often hear from nurses that they have been told to document all the fields by their peers or leadership. Overall, change the culture is hard. Even good change feels scratchy or uncomfortable. The second factor is process. Policies and procedures need to be defined, supported, and aligned to practice. We need to thoughtfully consider which fields are required instead of making them all required just to ensure they are completed. Self-imposed requirements, such as the need to fill out all the fields or document at a frequency not required, creates documentation burden. Facility and unit-based timeframes should also be standardized as to not create confusion with staff. The third factor is technology. The system should be efficient, effective, engaging, error tolerant, and easy to learn. We should identify areas of improvement such as system performance. Are the computers slow in patient rooms, causing them to delay documentation? Are pushing nurses to only use the computers at the nursing station, thereby creating less hardware resources for other clinicians to document on? Is the Wi-Fi at an optimal speed so that nursing can scan in the patient rooms? Or do they need to leave out of the patient's room in order to complete the action? Clinical decision support is important in increasing the quality of care and enhancing health outcomes, preventing error and adverse events, and improving efficient cost-benefit care, which promotes patient satisfaction. We also need to consider if we have enhanced our system by using time-saving automation, such as handheld documentation devices and IV pump and ventilator integration. We should also look at navigation. Is the system intuitive? Does it make sense to the nursing workflow? Should we move the documentation to a different flow sheet or navigator in the EMR? Can we consolidate the documentation as to have only one flow sheet, or do we need to keep documentation on multiple flow sheets as to not overwhelm staff or cause endless scrolling? There is a balance that must be achieved in order to create an effective system. These are a few guiding principles that were developed to guide us in reviewing requests for additions or modifications to the system. First, nurses are competent, ethical, and provide quality care. Nursing has been rated the most ethical and honest profession. We should not impose mandatory fields designed to monitor nursing behavior. This creates self-imposed burden. Second, all of the documentation should be supported by evidence-based research to provide high-quality patient care. Third, documentation should facilitate interdisciplinary communication. The documentation should have an impact on the patient's care. Is it meaningful? Fourth, does the documentation provide clinical decision support to assist nursing on the guidance of next actions, assist in implementing evidence-based guidelines, or supplement the body of knowledge? Fifth, the documentation should promote safety and quality, allowing for accurate and timely representation of the patient's clinical status. Are we doing the right thing at the right time for the right person allowing for the best possible results.